Hello, and welcome to The Two View, the cutting-edge educational show for PAs and nurse practitioners in emergency medicine and urgent care. I'm Martha Roberts, and I'm an emergency medicine NP and assistant professor in Northern California. I'm with my faculty partner, Michael Sharma. Hi, Mike.
Hello, Martha. This is Mike Sharma. I'm a practicing emergency medicine and urgent care PA in the Dallas, Texas area and an adjunct professor of PA studies. Today is a special show for you, listener, coming at you immediately post boot camp, still shaking the Vegas dust out of my suitcases. Every year that we do boot camp, we do these special question and answer moderated panels with all of our faculty members. This is honestly like my favorite part of the boot camp because it really anything goes. It's really like live, unscripted. In addition to the questions you can ask through an app with our boot camp faculty. So it's a really neat way, a unique thing that you're not going to get anywhere else, honestly. These people that you've heard on various podcasts like ours or on MRAP or whatever, you can come up and just talk to them like a regular person, or you can ask them questions that are answered on our panel on stage. What we've noticed, though, because we've done, of course, like a decade of these at this point, right? Every year, different participants, same questions. And we do our best to answer them in the course proper, but we notice that maybe it's just because of how we were taught in school, but some of these beliefs that are really myths in emergency medicine have a hard time dying.
Yeah, truly. It's, and Mike, it's the end of the year. And I thought, what a great way to kind of bring together everything we've talked about over the last year, but also, again, address some of these issues, just make them crystal clear as best as we can. So we're going to bring you this special post-boot camp question and answer series. We actually were planning to get to this PowerPoint at the course, but we simply ran out of time. We were so jam-packed. But yeah, it's like our year in review. So happy December, and we're deviating from our normal podcast flow. So don't expect our usual segments. We're just going to go right on through. We have a PowerPoint. So those of you that are watching this on this YouTube site, you will be able to follow some of the notes there. We're going to dive into some of the most entrenched myths in emergency medicine, topics we argue about in the break room. We whisper out, sign out. We teach sometimes incorrectly to students, or simply we just repeat them because that's how we were trained. EM is full of inherited practices. What our attendings maybe did 10 years ago, what a trauma surgeon maybe yelled once across the bay, or what we think patients might even expect. So some myths come from outdated data, other from medical legal fear, and many simply just from bad habit.
So funny, I was actually going through the archives today and I was listening to a podcast of the two of you that I did with Rick Bucata, with Dr. Bucata, the co-director of the boot camp, and we were talking about this very same thing. We are products of who trained us, and who trained us is a product of who trained them. The price for myths surviving through that process, we might think, oh, it's just inefficient, I'll make up for it somewhere else. But it's more than that. It's over-testing, it's under-treating, there's delays in throughput, and as you know, when we're doing things like boarding in the emergency department, that increases mortality throughout the entire hospital on the inpatient and the outpatient side. There's unnecessary radiation. There's bad resource utilization. And, when it comes down to it, straight up patient harm. People will have been harmed. And if but for us not doing that thing, they wouldn't have been harmed, So we are inducing patient harm by doing some of these things. We don't intend to, we don't intend to cause patient harm, but sadly enough, harm comes to patients sometimes, whether it's our intention or not. So today we're going to walk through several common mismanaged areas. Pain medication myths. Oh boy, do we have a whole podcast on this? Lab ordering habits, tox screen and alcohol level misinterpretation, low value imaging for back pain, contrast allergy folklore, subarachnoid hemorrhage workups, and contrast use versus renal failure or contrast-induced nephropathy. We're going to break down what's true, what's misunderstood, and what's evolving with modern evidence.
You know, Mike, I feel like a lot of these myths that people still practice are addicting. I find that sometimes it's really hard to stop doing something that I have been doing for a really long time. And it's just a simple human way. I think that I'm really addicted to ordering drug screens. Like, I just can't stop. I try, and it's really hard. And sometimes I just find a way to justify it. And, I was talking to our medical director about them and how much they really cost our hospital and how unnecessary they are. So we're going to dive deep into that. My addiction for drug testing might just be as strong as their addiction for the drug itself, I feel like. So I don't mean to minimize that. No, really. But in all seriousness, Mike, we're going to start with our first myth. One we have talked about on the show a time or two, but I want to put it right up front. And I do this because I recently, like in the last week, took care of a family member, a patient in the hospital, and a neighbor who were all taking 800 milligrams of ibuprofen. I just about lost my mind.
Now, we're about to go into a little video component of the podcast. So, listener, if you're a listener, consider coming to the video side of things. Go to YouTube and you can search for Center for Medical Education on YouTube. And then you can go to the podcast section of that. And then you'll find the video cast of this. All of the show notes, regardless of whether you learn to listen or learn to watch, regardless, all the show notes, any references we use today or from any podcast are going to be at our website. That is 2view.fireside.fm. That's the number 2view.fireside.fm. But for now, consider queuing up your web browser to the old YouTubes and finding us. So I'm going to go ahead and share my screen right now. Okay, here is myth number 1. For pain, if you're given ibuprofen, you should give 600 to 800 milligrams of ibuprofen, right?
The answer is no. Click the red no. No. Like, I can't believe we're still getting this, honestly. And I'm not trying to be condescending about it. It's just shocking to me that it's still a thing. The reality here is the analgesic ceiling dose of ibuprofen is 400 milligrams, meaning anything higher adds toxicity, not benefit. And a huge misconception in both inpatient and outpatient medicine is that more ibuprofen equals more pain relief. A lot of people feel that way about a lot of different drugs. Now, that might be true for some drugs, but not for this one. Pharmacological data shows that anything above 400 milligrams, the COX enzyme inhibition.
We can go start again, the entire thing. We haven't gone far.
Sorry.
That's okay.
Oh my God, Dave, I'm sorry. Inhibition.
Yep. It's fine. Yeah, I would have stumbled on that one too. Okay, here we go. Myth number 1. If you're giving ibuprofen for pain, the right dose is 600 to 800 milligrams, right?
No. Click the red no. The answer is no. Mike, I still can't believe that this is happening. And again, I'm not being condescending. It's just shocking to me. It's still a thing. The reality here is the analgesic ceiling dose of ibuprofen is 400 milligrams. That is the same as Motrin or any other ingredient that is ibuprofen in a drug. 400 milligrams for pain relief, meaning anything higher adds toxicity, not benefit. A huge misconception in both inpatient and outpatient medicine is that more ibuprofen equals more pain relief. That might be true for some drugs, but not for this one. Pharmacological data shows that anything above 400 milligrams, the COX enzyme inhibition plateaus. No additional analgesic effect is achieved. Larger doses only increase the risk for gastritis, renal injury, platelet inhibition, and bleeding. And the real risk here of bleeding is devastating if it happens.
Right, so let's be clear about this. The use of ibuprofen in adults for pain. 400 milligrams every 6 to 8 hours for most painful conditions. That's generally kind of the recommended dose nowadays. Looking at this inhibition plateauing. You can combine with acetaminophen for multimodal effect in certain conditions. Multiple trials support superior effect versus either alone, but be careful there. I'm going to asterisk this one is that there are certain painful conditions. Lumbosacral musculoskeletal back pain is one where acetaminophen may not provide additional pain relief. But I agree generally with that statement that often for other musculoskeletal pains, I'll say, hey, combo the ibuprofen with acetaminophen. So you might be thinking to yourself, well, what's up with the 600 to 800 milligram dose? Like, it's safe to do that, right? Well, why wouldn't I do that? Why would I do that? That higher dose is reserved for when you're treating an inflammatory condition. So beyond somebody just having arthralgia, like they tweaked their knee on the sports field, if they have straight up arthritis, inflammation, whether it's osteoarthritis, whether it's rheumatoid arthritis, other kinds of arthritis. So that would benefit from higher doses of pain, again, kind of more on the regular as well. You can't just take 800 milligram of ibuprofen one time and hit that anti-inflammatory effect. There's got to be a little bit more extended use there, but a topic for another show perhaps. How about post-operative pain? We mentioned kind of rheumatology flares, whether that can be joint pain or muscle pain or things like that. Or when your function is limited by some sort of inflammatory condition purely compared to your nociceptive pain, where it's just you have, again, arthralgia. You have your pain fibers are being judged by some sort of painful condition, straight pain relief, we can tend towards the 400 milligrams every 6 to 8 hours. We can start there and see what happens and probably don't exceed that.
Yeah, another one is maybe acute pericarditis, which we combine sometimes with colchicine. And those doses can be 600 to 800 milligrams every 8 hours for 1 to 2 weeks. But when those patients are getting those 6 to 800 milligrams, the recommendation is to provide a proton pump inhibitor or a PPI like omeprazole, 40 milligrams daily or the equivalent. So just things to think about when you're doing those high doses. Also think about pediatrics. It's still 10 milligrams per kilogram per dose every 6 to 8 hours and not to exceed the recommended max daily doses for them. And yes, still teenagers. They're not adult-sized kids, so still dose by weight. But Mike, why won't this myth die?
Well, you know the deal, right? If one is good, two must be great, and four must be fantastic. But I try to let patients know it's like I'm not trying to withhold medicine from you, right? I'm trying to right size your dose, but there still is this cultural expectation that like a strong medication means a high dose of medication. But take any other kind of medication, right? I could give you 6 to 8 milligrams of morphine or 1 milligram of hydromorphone. What sounds like it's more, helpful there? Well, it sounds like 6 to 8 milligrams of morphine, but we know that it's roughly an equal analgesic dose between your 1 of hydromorphone and your 6 to 8 of morphine. Beyond that expectation, we on our side want to play into our patients' expectations we're perceiving, right? We want to show that, like, because we know, right, not to say these words out loud, I guess, but the Press-Ganey scores. We got to talk about the Press-Ganey scores, right? Part of the Press-Ganey score is, did your provider treat your pain appropriately? Essentially, is the question, And so we don't want to give what could be perceived as like a little itty bitty dose and eat it on Press-Ganey later on. When we use a 400 milligram dose, that's really taking a stand for evidence and not what we perceive the patient may or may want. So there's like a lot of ways to handle this because, like many things, it's all about how you sell it and market it to the patient, right? So, I know you'll say this, Martha, sometimes like, this is the dose that science shows works best. higher doses only irritate the stomach and kidneys. So, you could go with that trust the science approach, right? But it's tricky. I think that a lot of times there are certain things about science that certain patients are really not interested in. They're interested in feeling better and not feeling worse. And so I think that's just kind of like my interpretation of things. And so I think when I'm having these discussions with patients, I kind of do what you just did there in the sense of I want to show that I'm trying to make them better. And I also want to kind of wave the flag a bit to say, if I do something else, I could make you feel worse. I could give you, now you've got abdominal pain. Now you've got, bleeding, from your bottom when you take a poop, and that's really scary. Now your kidneys don't work so well. Now, take your pick, any sort of NSAID toxicity here. So sometimes,
Mike, one of my favorite renal docs would say ibuprofen, fixing pericarditis and knee pain since forever, and simultaneously reminding us that the kidneys are optional. Just like our profession. The renal docs get so mad. Or how about this one? Why did the pericardium break up with inflammation?
I don't know.
Because NSAIDs said, don't worry, I'll take the pain away, but we're going to need to talk about your stomach.
Oh boy.
Yeah.
Okay. That's what dialysis is for, honestly.
Stop it.
Why does dialysis exist if not for taking NSAIDs? Okay.
Well, anyway.
Yeah, I think it's really important that we aren't really hitting every single topic here. There are many studies about this analgesic ceiling, but I think it's important when you continue to get in the nitty-gritty, understand what painful conditions were studied here. I'm sorry, I wish I could quote the actual evidence or guidance. I feel like in our patients with larger body habitus, there is some suggestion that, hey, maybe you go to a 600 milligram dose for patients with larger body habitus. I mean, we do that for things like TMPSMX when we're treating skin infections. We do that for, take your pick in terms of your opioid analgesia. We can weight base those things. So without spending too much more time here, those are times where I may kind of like play into the myth. Larger patients or larger patients.
There's always an if, and, or but, and, it sounds like my 11-year-old. So, let's go to the second myth, Mike. That's the end to that one. All right, myth number 2. I should probably order LFTs, right? Most patients need LFTs, liver function tests. I should probably get them, Mike, right?
Yeah, I think the jury's out on this one. I don't think you need to order the entire panel of LFTs. So let's start out with how much of a misnomer that is. Okay, so let's start with your AST and ALT. And of course, we call this the liver function test, the LFTs. You can throw in some bilirubin, you can throw in some alkaline phosphatase. There may be others like GGT if you're nasty. But in the end, these measure liver injury. They're liver injury tests. Like if you house a bottle of Tylenol, your AST and ALT are going to go way up. If you have hepatitis, whether it's viral or alcoholic or other kinds of hepatitis, that can also zhuzh your AST and ALT. But they don't tell us how well the liver is functioning. So if we care about function, we want to go down the PT-INR because what does the liver do? It helps us not bleed to death and other things. But that's one thing the liver does. And so you can get an INR if you're worried about somebody having a problem with their liver function. Bilirubin, albumin can also tell you how well your liver is functioning, doing liver things. AST and ALT really rarely change management unless there's a story there, an important story that suggests, oh my gosh, the liver is being damaged in a significant way.
Yeah, right, Mike. So understanding the lab helps us decide if we need it or not. And LFTs are a group of blood tests that measure all these things. The main goal is to understand how well the liver is working and whether there's inflammation, injury, blockage, or impaired synthetic function. But at the end of the day, I always like to think about, well, what is the organ? And what is it telling us? And what do I need to order to figure out my problem? This is another good reminder that if you can spend a day with a hospitalist, internal or family medicine, do it. Go watch them. Go to their rounds. I just love them. I mean, we could do a whole segment just on them, but that's a thought too.
Digging a little bit deeper, ALT or alanine aminotransferase is a more liver specific enzyme. When ALT rises, it usually means direct liver injury. Something is damaging the liver cells. AST or aspartate aminotransferase is found in a lot of places, to include the liver, also heart, also skeletal muscle, also kidneys and red blood cells. So if you see this big AST elevation, it could be from the liver, but it could also be any one of those other organs that are going wrong as well.
Yeah. So, Mike, I've noted that as clinicians, we pay attention to the AST ALT ratio sometimes. This is up for debate. It depends on who you are and where you're using it. But the thought is when AST is higher than ALT, especially when the ratio is greater than 2-1, it's often associated with alcohol-related liver disease because alcohol damages the mitochondria, where AST is concentrated. When ALT is higher, it's more typical of viral or metabolic liver injury. So, Mike, this is when LFTs are most likely appropriate. Okay. Maybe suspected biliary disease. The patient comes in with right upper quadrant pain, jaundice, or a fever. Alcohol, hepatitis, toxic ingestion, pancreatic evaluation, shocked liver after hypotension, known cirrhosis with volume overload, mental status changes, and also watching trends maybe in trauma or sepsis.
So when they might not be helpful are times like chest pain, when you're pretty certain the pain is from the chest and not just the upper abdomen. Headache. Maybe we'll get a metabolic panel for someone with a headache, looking for electrolyte issues or what have you, but do we really think that the liver is causing their headache? Probably not, right? Syncope, near syncope, again, is the liver going to do that? Viral upper respiratory infections, this is a real tricky one because so many times we can get a little spiked AST and ALT, even with the common cold, so to speak, but we order a CMP while we're at it getting other things and the AST and ALT are slightly elevated. What does that mean? What is the patient going to think it's going to mean? Is it going to lead to them needing more tests later on, more follow-up for this? Are they going to be thinking about how their liver is functioning over the next 2 weeks instead of focusing on just feeling better? So those are places where you'll see transient AST, ALT elevation. Your generic, non-specific abdominal discomfort without red flags, without concern for some of the things you mentioned, Martha, like biliary disease or alcoholic hepatitis, toxic ingestions, things like that.
Yeah, so Mike, my favorite hepatologist friend would say, Martha, be happy that the liver's not involved. Okay? Just be happy. All right? It's important to note that reflex testing for any lab, just that, let's do it, wastes resources and clogs labs that, really should be done for another person, it slows everything down. And this myth also, I think, shows kind of discomfort with uncertainty itself. Ordering everything, feeling safer. Like you said, like buying time maybe essentially for the patient to wait. So that LFTs won't change your plan in many cases. It can for some, like we just said, and the results don't equal decision either. So return follow-up and symptom-based care matter more. And Mike, this would be a great moment to debate defensive medicine and versus evidence-based practice, but we got more myths to get to. So let's get to just these last few things about LFTs before we move on to myth number 3. And just a few cases, we sort of already mentioned these, but case number 1, that chest pain, let's panel of everything them. 45-year-old male comes in, reproducible MSK chest pain, no abdominal symptoms, no jaundice, normal vitals, benign exam, the internal thought is, hey, let's, do the everything panel, CBC, CMP, LFTs, lipase, yada, 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 UA, troponin, because it's routine. results add 90-minute or more delay. Nothing changes the management. Patients get frustrated. And really, the conversation point here is, why do clinicians equate the panels with safety anyway? I mean, a lot of my nurses feel, okay, we got to order this panel. The panel's there for a reason. Maybe. But again, just food for thought.
I think, without getting too far into it, I think to some degree there is this inertia. Like, we've been doing it this way for years. It's to some degree harder to take a second with every patient and go, do I have to order the LFTs? When you could just say, I'm just going to order the LFTs and I'm going to use my brain power for something else. Maybe there's benefit in that, or maybe when you get used to it, that cognitive decision isn't so heavy all the time, right? So here's a time when it's easy, right? A patient with right upper quadrant pain, right? So a young person with sharp right upper quadrant pain, radiating to the back, vomiting, questionable fever. That's a patient I think needs LFTs. And what you can get is maybe a patient has LFT elevation here. Ultrasound shows some biliary disease and even duct dilatation. That would lead this consultation to surgery or GI, depending on who does your ERCPs. Okay, this could be acute cholangitis here. If we've got some jaundice as well too, which we probably do if the LFTs are elevated at a certain point. So that's a situation where you're trying to assess, is the right upper quadrant pain and vomiting gallbladder emergency or flamin' hot Cheetos, right? And so flamin' hot Cheetos not going to spike your LFTs. LFTs spiked with this, even if the ultrasound is reassuring, you have to kind of ask yourself, well, wait a minute, this person sounds like a gallbladder emergency, looks like a gallbladder emergency, the labs suggest a gallbladder emergency, but the ultrasound is reassuring. That doesn't add up. I need to look at the preponderance of the evidence here, and maybe you still consult surgery, still consult GI to say, even though I got a negative ultrasound, I'm worried about some sort of occult disease here.
Right. And lastly, the syncope workup gone wild. So, that's your teen patient faints at school while standing in formation for band practice. Normal vitals, normal ECG, no red flags. Old school thought, yeah, you don't need LFTs here. You don't need to throw everything at them. So,
Yeah.
But again, we're not saying don't ever not order them. You can order them sometimes. But let's get on to myth number 3. Number 3, Mike.
Myth number 3, here we go. Tox screens. And by the way, before we go on, this is you're addicted to this. I'll be honest, I'm addicted to ordering the comprehensive metabolic panel. Because I'm one of those people. I feel like I'm just going to order it because why stop and think? I'm just going to go ahead and order it. It hasn't burned me terribly, but honestly, I get sometimes where I have elevated LFTs without a clinical thing to pair to, and now I got to deal with it.
Yeah.
Anyways, myth number 3, tox screens and alcohol levels are helpful. Let's send them. Question mark.
I want to say yes, but I know that I'm wrong. So as my favorite psychiatry doctor would say, and as you've noted so far from the show, I've taken notes from everybody before we did this pod. Drug testing is like reading patient charts. Are you prepared for the plot twist? Are you ready for that plot twist? So there was a can. If there was a can of worms on my desk right now, Mike, it would have worms in it ready to explode here. We're opening a can of worms right now. Reality, most drug screens do not change emergency management at all, and many delay disposition unnecessarily. P.S. Mike, did you know the phrase opening a can of worms, by the way, became very popular in the 1950s? It became so popular by the 1960s. It was common enough that dictionaries recognized it as an idiom.
Can you buy worms by the can? Is that how they come? I thought it was like by the bag or something.
Well, now you can buy them by the Tupperware. That's how I get them to go fishing.
Yeah, okay, there you go. Right. I knew it's a plastic container of some sort.
Yes.
Well, anyways, getting to the point, without worms. When used correctly, tox screens are a tool like anything else, but they shouldn't just be a routine order for the, dizzy patient, for example, right? We can end there, but let's get into it a little bit. Drug screens in the emergency department live in this gray zone where we really question whether they change management. They can be helpful in some cases where maybe somebody is really sick and you really just don't know what's going on here. But there's controversy because they seldom alter immediate care and they can also carry ethical, legal, and social consequences.
Yeah. So the bottom line first, these are useful in those patients with altered mental status with an unclear cause. We don't know why. Maybe a patient with a first time seizure or unexplained neurological change. Also, maybe trauma where intoxication could possibly alter their disposition, right? So, not necessarily for the medical legal chain thing,
Hmm.
but where it might change your disposition, especially if it involves head trauma or something that would impair them from functioning when they leave. Maybe that's psychiatric clearance when it's required by your institutional policy. But quite
Oh boy.
frankly, this is a whole conversation in itself because why is that a thing anywhere? And remember, again, the thing about legal blood draws for DUI or chain of custody, that's a whole different test, a whole different thing. That's not just your run of a mill. Let me order the blood test and send it down to the lab. You can get yourself in a lot of trouble for that. So, another show for another time on the legal blood draw stuff.
Generally, these tests are not useful when you've already figured out the patient is intoxicated, right? Like you've adequately ruled out other reasons for them acting funny and you're treating their symptoms of intoxication anyways, okay? Or maybe you already know the substance by the patient being forthcoming, or you've recognized a toxidrome where it sure looks like they're on some sort of amphetamines or sympathomimetics otherwise, or opioids, things like that. Or also where doing this screening test, which often involves them peeing into a cup, doesn't change the disposition. If they're already going to be watched for the next however long until psychs clears them, if they're going to your observation unit to metabolize their way to freedom or otherwise have a condition observed, or if you already know they're going to have consultation, if these things are already on the way, then you probably don't need necessarily to order a tox screen just to order a tox screen.
Right. And so, Mike, here's some cases that we can reference to have or to have not the test. So, ordering a drug screen when a patient presents with isolated psychiatric complaints such as suicidal ideation but has no medical symptoms, normal vitals, normal exam. Many systems require tox screens before psychiatric placement, but the literature consistently shows it really changes their disposition or treatment. I wouldn't die on that hill, but it's like, psychiatric facilities have their protocol. There was a moment in time up till about 2 months ago where our psychiatric care center would not take a patient with a blood pressure that was higher than 140 over 90.
Uh,
We're not low. We're not doing anything about that blood pressure. Sorry, psych. I've even sent patients over there like 190 over something, and they're like, "We're not taking them. They're unsafe. They need this." No, they don't. We're not. No. They're on drugs or they're this or they're not taking their Norvasc or whatever. That's why their hypertension is raging today. But no, I'm not gonna urgently do that. Quickly lower it and send them to you. So, just a little side piece.
Briefly, that war is going to be won in a director to director discussion.
Right.
As much as we don't need to do this, the right thing is not to make a fist about this at 2 a.m. on a Sunday. Like you kind of have to go through and go along to get along, and then maybe have the discussion with your chief on Monday and say,
Yeah.
I see us doing a lot of these tests, and I'm not sure if we need to do this. Do we have an avenue to talk to our psych team, and maybe we can kind of get some more throughput going a little faster. In cases of altered mental status where the patient is protecting their airway and you're treating empirically for what you think is going on based on the toxidrome, basically the clinical picture and what it suggests. Maybe you're giving some glucose, maybe you're giving thiamine, maybe you're giving naloxone as you need to. A tox screen may not alter acute care if you're already treating anyways, and it rarely identifies the substance with specificity quickly enough to change interventions. Yeah, as we've heard, these are screening tests. They're not necessarily definitive diagnosis tests. Those can take days. Before medical clearance for detox or rehab patient, when the detox facility accepts patients regardless of the substance type, then again, if it's not going to change the placement, they're going to take the patient regardless of what they are or not using, then, why order that panel? But if that facility is making a fist and they need it to be done to check a box on their end, maybe you check the box and then have a discussion on Monday with your chief.
Yeah. And then the last one, Mike, there are many more. We can talk about many more. And we could go on about that topic for a while, but trying to prove noncompliance or malingering, that can be more punitive than therapeutic. So skip that one too. All right, Mike, you're not going to believe this next one. I had a few people still talk to me about this one at boot camp. I mean, wow, I thought we figured this one out. Now, there are some caveats to this, but the myth number 4 is back pain needs an X-ray. So I want to keep this one short without doing too much deep diving, but what's the reality here, Mike?
No, don't do that. Please don't do that. Okay. So what's the reality? The vast majority of emergency medicine back pain, in terms of back pain coming to the emergency department, especially if somebody who walks in, is benign and requires no imaging. But it's tricky. You have to differentiate the routine musculoskeletal pain from those rare times, and I mean they're pretty rare, when there are red flags concerning for true emergent pathology.
Absolutely. So I say you don't need an image. The literature says you don't need an image. There might be a little gray zone with some of these other things, but most of the time, I'll never say 100%, but most of the time, you do not need an image when there is no trauma. There's no fever or systemic symptoms. There's no signs of cancer, weight loss, or intravenous drug use. There's a normal neurological exam. There's no bowel or bladder disturbance. You don't need an X-ray or a CT or an MRI in those cases.
When would you want to consider some sort of imaging? We're not saying X-rays, but something. This will depend on your practice setting and other things. When you've got a patient over the age of 50 with new and severe pain that they've never had like this before. That's kind of weird. By then, someone's usually gotten at least one round of musculoskeletal low back pain. Somebody with a history of cancer or immunosuppression of some sort, and we're going to include steroid use in that immunosuppression. That's the downside of steroid use, is that can affect our bone health. IV drug use can lead us, of course, to concerns about epidural abscesses. Trauma can lead to fracture, and sometimes even minor trauma can lead to a significant or at least a clinically obvious fracture. It's really going to depend on the patient, how dense their bones are, et cetera, et cetera. Of course, if you have things like saddle anesthesia, well, I ask the patient, does it feel funny where you wipe after you go to the bathroom? If there's honestly any kind of bowel or bladder disturbance, like the technical thing for cauda equina, the first thing people feel is urinary retention, right? So that's the most concerning one. Of course, stool incontinence, that's number 2, no pun intended. But also, right, what happens when you retain enough urine? Eventually, the bladder is at its capacity, and so now you start to pee, and maybe pee a lot. And so now the patient can describe, oh, I'm having urinary frequency. And if you take that at face value, you're missing how it was preceded by urinary retention. So me personally, if you are peeing or pooping different than you usually pee or poop with back pain, I'm taking it seriously. I'm considering imaging. Now, in terms of what kind of imaging, right? X-ray almost never changes management and adds radiation without value. I will say this, sometimes I will order kind of the screening X-ray if it's quick, if we're going to be waiting a long time for MRI or CT, especially in our older patients.
Yeah,
when I'm worried about cancer, right?
Yeah, I was just, Mike, you read my mind. I was actually just about to say, so, it's possible if you get that plain film of the back, like if this is, some kind of mets to the bone,
Yeah.
because they have some new focal bony pain. Certainly, infection concern with bony destruction is going to be a late finding. But yeah, that's a really good one. And I meant to put that in my other list.
Well, I mean, we both have dealt with this, and I will say, I've taken care of patients with low back pain for over 15 years. Trauma, no trauma, things like that. And I can remember the patients where I found the lytic lesions.
Yeah.
There were two. There were two in 15 years.
Yeah.
I've looked otherwise and thankfully haven't found any. And so I'm reassured by the fact that I am X-raying more than where I find them. I'm getting
Yeah.
a fair amount of negative X-rays, but I'm doing it for the right reasons in these older patients, in these patients with risk factors. So if not X-ray, then what? Usually MRI or CT is what we're going for. CT good, generally speaking, for fracture. If you're concerned about fracture, CT is great. MR is more for soft tissue. So your cauda equina syndrome, your spinal epidural abscess. I want to throw in there spinal epidural hematoma. If your patients are on some sort of anticoagulation,
Mm-hmm.
that can also lead to the same kind of problem as an abscess does. You have this rapidly expanding mass compressing the spinal cord, and so consider anticoagulation as well.
So you can check out the Choosing Wisely campaign from ACEP that both discourage X-rays for uncomplicated back pain because they rarely change treatment. And as my friendly radiology friend would say, I have a smart phrase for that. It's I write mild multi-level degenerative changes, which, by the way, he would say, are basically wrinkles on the inside. Ah ha ha ha. That's what they would say. It's funny in the moment. Anyway, Mike, talking points to finalize here is that X-rays may normalize the patient feeling better, but they really aren't good for anybody in most of these cases. And you can use your scripting that this exam tells me this isn't dangerous. These are the reasons why. Imaging won't help you feel better or change the plan. Yada, yada, yada. Okay, so that's
Yeah,
that.
that's a tough one, right? Because people come in with these expectations, and so I personally, I I cheat to the other side of their concern. Like they're concerned at a 9, I express concern at a 9.5, and I go, wow, like you're obviously in this terrible pain. And the good news is I have a lot of ways to help you feel better. There's things you can take by mouth, things you can put on the back, and X-rays are really not the best for the back. You probably need, I mean, if it doesn't get better, you need like a CT scan, you need an MRI. And the good news is we don't need to have those things done now. We're going to touch up with somebody who can do those special tests. And by the way, X-rays, that's a lot of radiation to the old gonads. Okay, the
Yeah.
testicles, the ovaries, the belly, and radiation scatters. That's going to go to your breast tissue, to your thyroid, to your brain. I'm worried about giving you cancer. You seem like a nice person. I don't want to give you cancer in a few years for this back pain. So I want to set you up if you need to with a scan that involves no radiation at all. And that's going to be something that my colleagues in family medicine can order for you. Can I get you an appointment with those guys? I kind of try to steer the ship a bit.
Love it. Okay, let's move on, buddy.
Next myth: the patient is, quote, allergic to iodine. So does that mean I have to only give a non contrasted CT for them?
What is no?
I'm feeling a trend here, Martha. There's a lot of no answers today.
It's my
It's
favorite
very
word to
no
say.
focused.
So, look, I want to spend a ton of time on CT stuff, Mike. I really do. But we have other episodes about
Do
this.
you?
Well, I want to just reiterate the information, and I want our listeners to go take a listen to Dr. Robert Tubbs on our prior show, back on episode either 48 or 49, with a really wonderful dialogue about this. But In reality here, Mike, iodine allergy does not exist. The body requires iodine to survive. Shellfish allergies come from tropomyosin, not iodine. The only relevant factor is prior reaction to IV contrast. So this is the short and sweet. If there is a prior reaction, follow the American College of Radiology or the ACR pre-med protocol. Prednisone, 50 milligrams at 13.7 and 1 hours before, if you can. And then diphenhydramine or Benadryl, 50 milligrams, 1 hour prior.
Right. And, we're going to miss important things sometimes when we're not giving contrast. Dr. Tubbs's podcast with us is probably in my top 5 of all the podcasts we've
Yeah,
done, honestly. It was such
it
a
was great.
good podcast covering such important questions we ask ourselves every day, or maybe more accurately, the rad techs ask us every day, right? And so missing that contrast, we could fail to see that subtle abscess, fail to see that subtle bleed or what have you, So PE, dissection, stroke, these are conditions that will really benefit with the addition of contrast. And so you can script it by saying, there's iodine in chicken, there's iodine in salt, and thankfully we both get to enjoy fried chicken. We love our fried chicken, and you're getting plenty of iodine there. What you're not getting in that chicken is contrast dye, okay? The contrast dye is what you had a reaction to back in the day. And, just because you had one time doesn't mean you're going to have a reaction in the future. Understandably, you want to understand what that reaction is. Whenever somebody says they had an allergy, your question and my question always next should be, what happened? Tell me exactly what happened. And often you'll find that it was a little bit overblown or misunderstood.
Yeah.
Number next. Should I do an LP if the CT is negative to rule out a subarachnoid hemorrhage?
Okay. I'm going to say no. Okay. We go on and on every boot camp, back and forth, back and forth. But really, there's some good literature on this, and we're going to cover it again just to remind you all. No, if it's less than 6 hours. Okay. And also, what is your clinical suspicion? And the timing matters. All right. So the reality here is a CT within the first 6 hours after headache onset has about 95 to 99% sensitivity, with some studies showing nearly 100%. After 6 hours, breakdown of blood decreases, visibility and sensitivity falls. The modern approach is CT, CTA, neurosurgery consult, especially when suspicion remains high. Remember, there are complications and disadvantages when adding on an LP, really getting an LP for anything. But in this particular case.
Yeah, you can have complications like traumatic taps or other contamination causing false positives. Now you could have a post-LP headache, and now you got to deal with that. You're adding to a patient's problem list. CT technology has really come a long way since the advent of this technology, and your modern CT angiogram is identifying these aneurysms or other vascular lesions that even LP can't. This is a place where emergency medicine practice is really evolving. It may be very site dependent in terms of protocols. So even though we have our opinions that are to some degree based on where we work individually, we also know that this is something where it's kind of a struggle. The struggle is real, and it can really vary based on the people that practice around you and where you practice.
Yeah, so let's just do a few short cases just to kind of clarify. And again, subject to interpretation, there are many variables. Case number 1, the thunderclap headache 2 hours ago. Worst headache, it just came on, worst headache of my life. It was horrible. CT at 2 hours is negative, neurologically intact. Do I need an LP? No, you don't. You really don't need an LP. Shared decision-making, conversation opportunity as well. That's that one.
And I think you mentioned something that I want to make sure it's not glossed over by the listener here. Neuro intact. Neuro intact at arrival, neuro intact after the scan. You do multiple serial neuro exams, and you're showing, hey, the pain's getting better, the neuro status is not progressing in the wrong direction. We can stop here after, again, some shared decision making. How about another case? Somebody comes in at 18 hours of headache. CT is negative, but you're still concerned based on the description of the pain, whether it was a thunderclap headache, maybe there is some, altered mental status or other neurodeficits here. This is where a CTA could find an aneurysm. And if it's an aneurysm that hasn't ruptured, there's nothing for the LP to find.
Right.
So the CT angiogram, especially with modern CT technology, these later generation, newer generation CT scans, they can find those itty bitty aneurysms that an LP won't.
Right. As my favorite neurologist would say, Mike, she says, neurology is the only specialty where I can spend an entire hour with a patient, do a perfect exam, and I might still end up saying, well, so anyway, we'll get the MRI, okay? So.
That's like us all the time in the ER, like, we're just going to CT you,
The other thing is I know a neurologist that says fascinating all the time. No matter what you say to this guy, he's like, that's fascinating. And you know that it's not, right? Anyway, next myth. I think we're getting to the end. We only have 2 left. No, this is the last one.
I think it's the last one, yeah. I think everybody is fascinating if you look hard enough and you allow yourself to be fascinated. But anyways, that's more philosophy. So, last myth. I can give contrast to patient renal failure if I need a CT scan. Can I give that contrast to the patient in renal failure?
I'm going to spell this one for you. I'm going to spell it. Ready? I'm going to say...
That's a lot of letters.
No, well, I was going to say, no, you can give the contrast.
Oh, okay.
But I was going to spell N-O. No.
Oh.
However, sometimes it depends. And the reason why it depends is for all of the reasons that Dr. Tubb talks about in our previous podcast, but we're going to keep this short and sweet. So tell us the reality, Mike.
Yeah, it comes down again to we mentioned in the last myth is the problem you're worried about, is the diagnostic study for that problem one that benefits from having contrast, right? If you're worried about an occult fracture, well, I don't care about using contrast there. I'm looking for things like a kidney stone, right? I think it's renal colic. Well, I don't need to use contrast there. That's a non-contrasted CT. But it's something, again, like we talked about earlier, an abscess, a bleed, things like that. Well, that's where you may need to use contrast to find the subtle things that suggest that true emergency, Just like CT technology itself has evolved, the contrast has evolved. Like the contrast we get today is not your grandpa's contrast, to use a phrase, right? Modern contrast is way safer. You can get into a lot of kind of nerd stuff there, but short and sweet, new contrast, safer, okay? And the risk of nephropathy from contrast-induced nephropathy, CIN if you're nasty, is way lower in 2025 than it was back in the day. Because again, it's a different kind of contrast. Even in a patient who doesn't make pee anymore and is on a dialysis schedule, it's safe to give that contrast because guess what? They're on a dialysis schedule. They're going to get dialysis, they're going to get that sucked out of them, and it'll be fine. Now, what if you're a little concerned here? Maybe you've got a patient who has a history of a kidney transplant, or they have some sort of chronic kidney disease, not to the level of dialysis. Well, what you can do is you can hydrate the patient. So if there's no contraindications, you can hydrate 1 liter per kilo per hour with normal saline before and after, okay? Or you can consult a nephrologist, and the nephrologist can help you out there. That's why nephrologists are on call, is to help you out with that. So things you can mention with the patient who's concerned. Hey, back in the day when they had less safe contrast, yeah, I worried then too about hurting somebody with contrast. But we use much safer contrast nowadays, but that kind of like hangover from history is still there. Okay. The problem I'm worried about with you, I'm worried we're going to miss it if we don't use this contrast. And I just would hate to miss this real emergency I'm worried about, and then you get sicker, and then we have to do more serious stuff. There's consequences to missing the problem that I think you have today. We can deal with your kidneys maybe needing to flush that contrast out a little more aggressively. We can help you flush the contrast out, okay? But that's what I think, patient. I think it's very safe and very important we get this contrast. But what do you think? What do you think we should do here? What are your concerns about this contrast? And sometimes you never never refuse to be surprised by your patients. Okay, the second you don't allow your patients to surprise you is when you're missing things that can really impact the patient's care. And sometimes you just have to ask the patient straight up, like, what exactly are you concerned about? What can we do here to help you be more reassured here? And sometimes they'll give you something that you were not at all expecting, and you can easily kind of reassure and deflect.
Yeah. So, Mike, I mean, we have other medical myths that we could talk about, but we have reached about our talking point. So we're going to wrap things up for today. And I'd like to end with one of my favorite things an ER doc once said to me. Unless you have one that you'd like to talk about with a nephrologist, because I have all my one-liners from my docs that I went around and asked.
I have no friends in the hospital, so no, these are all good for you. I'm kidding.
What do you mean you have no friends?
I have a ton of friends in the hospital. Hi, Cora. How are you doing?
So this is a good one. All right. So I said, give me a good one-liner from one of my favorite docs. And they go, people want to know what it's like working in the emergency department. And I want you to imagine juggling chainsaws while someone's asking you for a sandwich, while another person insists that chainsaws are their emotional support animal. That is literally, I mean, that sounds about right. Anyway, it's time to wrap up tonight's session on common myths in emergency medicine. And we hope this conversation inspires you to keep questioning assumptions, practicing with intention, and elevating the standard of care through evidence and curiosity. And we want you to fly high here and keep looking at the data. Day or night, we want you to take flight. All right?
That rhymed very well.
You like that? Put some effort into that one.
Our two-view trivia question: which complication of diverticulitis can present with pneumaturia, air in the bladder, and recurrent UTIs due to an abnormal connection between the bowel and the bladder? Our two-word answer is colovesical fistula. And our winner this week is Lisa Jin. Lisa Jin is a PA kind of making a transition in her professional life, now coming to the dark side of emergency medicine more fully. Welcome. We have cake and cookies. So congratulations, Lisa Jin. You can get 20% off of any one of our streaming courses. What streaming course, you may ask? Well, that's up to you. You and everyone listening can go to www.ccme.org. That's www.ccme.org. That's the Center for Medical Education. You can see all the courses we've put on throughout the year.
Nice. Okay. So for our new question, Mike, I wanted everybody to take flight. So this is our two-part question. Part 1, what is the only mammal capable of true flight? Part 2, on average, how many miles can it fly while hunting?
Email us your two-part answer, in addition to anyone you'd like to give a shout out to, as well as any feedback or comments about any episode or our new format, to 2viewcast@gmail.com. That's the number 2viewcast@gmail.com. More information on the original and the advanced emergency medicine boot camps, the emergency medicine and acute care course, or any of our courses are available, again, at the Center for Medical Education website. That's www.ccme.org, www.ccme.org.
New and upcoming courses to be announced soon for 2026, Mike, and that is including our advanced boot camp. So keep checking back for more. Really super excited.
Thank you for listening to this episode of The Two View. You can subscribe and rate us. Please do rate us on Apple, iTunes, Podcast, and Spotify. Search for Two View Emergency. That's the number 2 View Emergency. It'll come right up. Ratings help us climb the charts so that other clinicians get some Two View goodness just like you did today. If you like YouTube, you want to see our festive Christmas sweaters, then go to the video blog instead. Search for Center for Medical Education on the YouTubes, and you can catch the video version. You can also see the PowerPoint slides we were using, tastefully designed by Martha. Nice job, Martha. Don't forget our website where you can go next level on any of our topics from any of our episodes, including all the papers and sites we referred to. That's twoview.fireside.fm. Our audio and video engineers are Ricky Bucata and Dave Pett. Thank you, fellas.
Thank you again for tuning in, friends in EM. Share this podcast with a friend. Share your thoughts via email. And thanks for sharing your time with us today on The Two View. Have a good day and a great shift.
And a happy new year.
I don't know why I can't talk. It was a long show.